Welcoming today Dr. Michael Hosokawa as our speaker. Dr. Hosokawa has had a full day. He's been speaking to various groups, and I think we've gotten some really good ideas about problem-based learning and about looking at our curriculum, at our courses, at our teaching a different way. Dr. Hosokawa is professor of family and community medicine at the University of Missouri School of Medicine. He's been there for quite some time, and in his time there, in fact early in his time there, he was commissioned to change the curriculum of the University of Missouri School of Medicine to move into the 90s at that time, to try something radically different. That difference is problem-based learning. I worked a bit with Dr. Hosokawa when I was on faculty at the University of Missouri myself. Then when I went to Tennessee, we were facing a crisis in teacher education. Teacher education over the past 20 years has faced a great deal of criticism. Part of that criticism has to do with the linkage or the connection of coursework in teacher education to actual practice in being a teacher. That's what problem-based learning is about. It's an authentic way to learn content within the context of practice. Dr. Hosokawa came to Tennessee and essentially is the father of PBL in teacher education in Tennessee because he changed the whole state. To this day, teacher education in Tennessee is based on problem-based learning. Based at least on those two instances, and he has a much greater history than that, Dr. Hosokawa has a rich knowledge base, a rich set of expertise to share with us about how we can look at our own curriculum and our own courses in a different way to increase the authenticity, the relevance, the engagement of our students and their learning. So I don't want to take any more of his time. I'm excited to hear what he has to say, and so please join me in welcoming Dr. Hosokawa.
Thank you. That's one of those introductions that my father would appreciate and my mother would believe. My relationship with Dean Short and with his wife has been one of the most rewarding professionally that I've had and hope would continue, and I very much appreciate being invited here to the University of Houston, Clear Lake. And so what I've seen so far, what I've heard so far, and what I've experienced so far leads me to believe that this is a very forward-looking institution, one that could consider change. But if problem-based learning, or if you want to call it project-based learning, might be a part of the curricular change that would enhance learning. So what we're really talking about here is that the status quo is unacceptable, and we're always looking for better ways to do things. So my plan is to go through a fairly formalized slide set that I put together to talk about the background and the structure of problem-based learning. And then I know that some of you have to go at various times. You have class commitments or other kinds of things. So, I'm used to physicians whose pagers go off in these kinds of meetings all the time. Now, in most cases, they told their staff assistant to page them 15 minutes into the presentation. So if they didn't like it, they could leave. And it's amazing that a fair number continue to sit there, and you think, what happened to their patient? But if there are people who want to stay longer than the formal part of the presentation, I did bring a sample case. and actually would put you in a learning situation and work through that. But you will not have to take notes unless you really want to, because I'm going to leave this slide set with Dr. Short. And so if there are pieces and parts of it that you would like to review, you're welcome to do that. Basically, what we're asking today is what's wrong with education? I hear so many times, if it ain't broke, don't fix it. That's not only bad grammar, but it's pretty lazy thinking. We never did it that way before. We've got a generation of learners coming along who are much different than our peers. And so we get into the situation of teaching the way we learned, and it doesn't fit anymore for today's learners. Unfortunately, we tend to teach that there is one right answer and one pathway for getting to that answer. And this is really squelching creative thinking. We used to have problems like this. If a train leaves the station at 8 o'clock going 40 miles an hour and the train B leaves the station at 9 going 50 miles an hour, when does train B run into the back of train A? Now, I've never used that or had to use that. So when Dr. Short talks about using real or authentic cases, I think that's one of the keys. We teach like we learn, homework, lesson plans, that sort of thing really is not consistent with creative learning. And technology is changing the way we communicate and the way we observe. Now, we were trying to teach our students to do a patient history. And so in a simulated situation, they interviewed a mock patient and took a history. One of the things we asked was, what's the patient's mood? I don't know. Well, how did the patient appear? Well, he just sat there. Did he appear differently? Was he excited? Was he tense? Was he worried? Was he in pain? I don't know. Many of our students today are so used to communicating with people that they don't see. I flew in here and the flight attendant said you could use your cell phone now, and about 2/3 of the group on the plane were talking to people who weren't there. And our students have lost their sense of nonverbals. So they're not observing how people are communicating. They're simply listening. Well, it's a good thing to listen, but you need nonverbals too. And I think we are overemphasizing evaluation. Those of you who are accredited, whose programs are accredited, or you're thinking about licensing or licensure or certification and so on, we've gotten to the point where that's really been carried too far. And it's the tail wagging the dog. And it's also interfering with creative education. So we say the future is really, if it ain't broke, make it better. The status quo is unacceptable. And what we're emphasizing with problem-based learning is it's just-in-time learning. Professionals learn just in time. That's when it's needed. That's in a context. Versus just-in-case learning, which is just in case it's on the test. And what we're trying to do is to get away from rote memorization long enough to pass the test and get information that you use and apply and you remember in a context, because we learn as stories. We learn about each other by exchanging stories. We learn about life with stories. We solve problems, and that gets stored as a story. So we're talking about learner-centered education rather than faculty-centered education. We're learning to use the internet because it's an external brain. I guess facetiously we say where there's death, there's hope. Faculty turnover is good because some faculty have been able to adapt. Other faculty can't adapt to this. And thinking and problem solving is hopefully replacing memorization. Now, we've made a lot of progress. I was very disappointed. I'm no longer in the dean's office, and I was disappointed that today's leadership put this picture at the top out as the new University of Missouri anatomy lab. That anatomy lab looks like it did 50 years ago. This is Stanford's anatomy lab. This is creativity. This is using today's technology for teaching anatomy. University of Missouri, building a new building with a lecture hall. Stanford University, a lot of small group learning and use of technology. This is the kind of forward thinking we need to think about. Some of you are old enough to remember the bookmobile. Came around every once in a while, and you could go check out books, and then it came and you checked your book in and checked new one out. This is today's bookmobile. Come and download. So these are the learners that we're dealing with. Learners who are technically savvy, learners who know how to use the internet as an external brain. The challenge for today's teachers is that can our teachers teach for a world that they cannot imagine? Now, one example I used when I was in school, we learned to do square root. I could do square root with a tablet and a pencil. It took me about 3 pages, but I had the formula memorized. And then a few years later, people were giving out these little credit card-sized calculators that would do it in one stroke. So we have to be able to teach for a world that we don't really conceptualize of. There is a knowledge explosion today. About 50% of what we give our students, what we teach our students today, is going to be obsolete. It's going to change, or it's going to be incorrect in about 4 to 7 years. So the half-life of biomedical knowledge today is about 4 to 7 years. For us, it means that what we teach our medical students today will be out of date. Half of it will be out of date by the time that they're in practice. And this is, of course, the internet, or a conceptualization of the internet. Tremendous encyclopedia of everything. It's the external brain. What you have to be able to do is to use it wisely, because there's some junk in there. This was a computer, home computer, as it was conceptualized in 1960. Now, I don't think anyone really has one of these. So the role of the teacher is changing. The role of the teacher is changing now from being the lecturer and the authority of everything and giving you knowledge as you understand it, to trying to think futuristically, to being the coach. Now, in 1989, 1990, we had a new dean, Lester Bryant, who's standing in front. Every one of those plaques behind is a former dean, so we call this the Hall of Dead Deans. But Lester was one of those forward thinkers. Lester was the one who really began to tell us that the status quo was unacceptable. And so Lester called me and he said, I want to change the curriculum. It's a perfectly preserved 1960s curriculum and it's 1990. And I said, sure, we can buff up anatomy and buff up physiology. And he said, no, I want you to change it. I want you to change it to the way people learn. Well, it's really a lot of fun and scary when the dean says, we're going to change. I'm not going to tell you how it's changing, but we're going to change because there has to be a better way of doing things. That's the kind of thing I'm hearing from Dean Short, is that let's explore better ways of doing things. And when you have a leader like that, that's an opportunity. So the challenge to us was to prepare students who would live in a world we can't imagine. Our graduates are never a finished product, that we're into teaching lifelong learning. Life is the application of knowledge to solve problems. That's what we're all about. As children, we had to learn the best way to get to school without getting run over. We had to solve our problems in order to function. So that, and also being a teacher or being a scientist or being a health professional is fun. So that learning to be one of these professionals should be fun also, and that problem-based learning we found to be more fun than sitting in a lecture listening to somebody pontificate. And so what we're focusing on is just-in-time learning it now when we can apply it and in a context, versus just-in-case learning, just in case it's on the test. So we're trying to look at ways that we can create a method for just-in-time learning, because just-in-case learning, a lot of it was rote memorization, had little relevance to the student, and was totally out of context. Now for the educators, you know Bloom's taxonomy. In the traditional curriculum, almost all of the activity went on in the lower sections of the taxonomy. What we're trying to move is to put learning up in the upper part of the pyramid. Let me review just briefly what the medical school curriculum looks like. The first 2 years are learning the basic sciences: anatomy, physiology, pharmacology, microbiology, and all the other ologies. The second 2 years is clinical practice. Take these students, put them on the wards, and now they're learning patient care. No crossover between. During the first 2 years, they sat in lecture about 40 to 50 hours a week. And it was for them, it was like drinking out a fire hose. Just so much information coming at them to, they thought, memorize. And they learn from professors and from books. As you know, books are out of date before they're in print. Professors, many of them, badly out of date, unless they're making an effort to keep up. For the scientists, how many times did you learn the Krebs cycle? Probably 7 for me, and I still don't know it. Put it into a context, might remember it. Oops. So we had what I called a bucket curriculum. We had an anatomy bucket and a biochemistry bucket and a physiology bucket, and the students learned all those sciences in isolation from others. So they learned about the heart structure in anatomy. They were able to dissect the heart out of the cadaver. Biochemistry, how's the heart affected by the biochemistry of the body? No idea. Had to wait until second semester to find that out. How's the heart function? Too bad. You got to wait for second semester for that too. So one of the first things I wanted to do was to integrate our curriculum so that students would learn things in a context again, rather than in isolation. And so it would begin to make sense. Some of the professors that I talked to had never met faculty in the other departments. So we wanted to create a curriculum for professionals in a way that professionals learn. That is just-in-time learning. We learn through stories. When you meet somebody, they say, well, I'm so-and-so, and I'm from Dallas, and I went to school at Texas Southwestern. That's how we get to know each other. Didn't tell us much about the person. But as you get to know that person more, you begin to exchange stories, and that's the way we get to know people. In the same way, that's the way we can learn, is that we learn through stories. And of course, traditionally, the groups or cultures pass down knowledge through stories. Students can learn without being taught. That was hard for some of our faculty to accept. One of the microbiologists came to me and he said, wait a minute, I want to make sure that my 8 lectures on cholera remain in the curriculum. I don't want you to revise those out. And I said, well, I'm going to give you one class meeting to talk about cholera. He said the entire class will be incompetent, you're going to be guilty of educational malpractice, so on. I said, Dick, we haven't had a case of cholera in Missouri in 30 years. They're still going to be incompetent. And he's still mad at me. In problem-based learning, which is the curriculum we were designing, the students teach each other. So that to teach is to learn twice, because you not only learn it, but you have to learn to break it down, to put it into context, and then teach it. We emphasize skills over just content, so that it's not only the learning skill, the teaching skill, but also learning the content. And so we wanted experiential learners rather than people who were simply sitting in a lecture and supposedly soaking in lots of information. And I spent some time sitting in the back of the lecture halls, and I would say maybe at least 25% of the students were either on eBay or Amazon. But they were also recording the lecture so that you just made sure they got everything. So problem-based learning was the development of authentic patient cases developed as a mystery. They were formatted to unfold. The PBL process is to receive the introductory material on this patient case, review it, analyze the problems, and clarify descriptions and learn new terms. Then an open and free discussion of the problem where the learners bring in their own knowledge and their experiences. Development of hypotheses. What could this be? And articulate learning objectives. What is it we need to know in order to move forward with this patient case? Some self-study, sharing of information, refining the hypotheses, testing them through additional information gathering, and then continue to an outcome or a diagnosis. And with some of our cases, it's to continue to a management plan for that patient. So we have a puzzling skin lesion. Janet Brothers comes on April 5th, combing her hair. She knows that she's got this small red swollen area on the back of her neck. It wasn't painful. She continued her normal daily activities. The swelling increased, the redness continued. It spread across her neck and her upper chest. And throughout the day, by late afternoon, the swelling became quite painful, and she experienced no dysphagia, which is a doctor talk for she didn't have any loss of vocabulary or ability to speak. She had no sore throat. She had no shortness of breath. So that's what the students get. Again, they're working in groups of 8. The sessions The problem-based learning sessions will take place on Monday, Wednesday, and Friday morning. And it's all morning. So they're sitting in these groups of 8 of students randomly selected from the class. So each group is mixed with disciplines, with background, with experience, may have nurses in a group, may have social workers in a group, may have musicians in a group. They all got into medical school because they had to take 4 required courses: chemistry, physics, advanced math, and biology. But that's the common denominator. So all of them brought unique experiences, unique background, unique understandings. That's the case. Now it's up to the group. So they ask, what causes the lesions? She has no sore throat, no shortness of breath. Why is it getting worse? They wouldn't know what dysphagia is, usually. So if I were facilitating the group, my natural reaction would be, I'll tell you, because I'm an expert. My role as a facilitator is learning objective. You guys don't need to go find out. So that the facilitator is not a content expert in this group of 8 students, which has a group of 8 and a faculty facilitator who is not a content expert. Another case, Jennifer Moretto. She has complaining of a stomach ache and becomes more painful. What more information do you want? You got to know what Jennifer's been doing. Did she eat anything strange? Has she been around kids with similar symptoms? Have they traveled? So that the students have to develop the questions which help the diagnostic process. This is all based on constructivist learning theory, which says that we learn in a context. That's basically what it says. It's a lot fancier than that. But if you want to know more about constructivist learning theory, that's a learning objective for you. Go research it. So the role of a faculty member has changed from being the source of all knowledge to being a coach. And this is simulation at its best. Now, you wouldn't want your pilot to be learning on you. So they go through a simulation training. They get realistic situations that they must solve in the simulator. So problem-based learning is learning to be a doctor rather than about what a doctor is or what a doctor does. They are in the situation where they are actually problem-solving a situation. They are the doctor versus this is what doctors do. So this is a form of simulation. Now, I know some of you are more experienced with things like game theory, like role-playing, those kinds of things. All of this is simulation. Those of you in the behavioral sciences, you work on cases. Law uses cases. Medicine was using straight lecture, feeding information, one right answer. And so we had to change. And so one of the ways in which we changed was to think more about simulation. Simulation has tremendous potential for learning, particularly in the health professions, in teaching, and in the behavioral sciences. So what we designed was a curriculum. In year 1, we have 4 10-week blocks. Each block is 8 weeks for learning, or 8 cases, 1 case each week. 1 week for evaluation, no pop quizzes, no midterms, focus on learning, and then 1 week break. 4 blocks in the first year, 32 cases. In year 2, same thing, at a more advanced level. So in block 1, the cases all focus around those areas, biochemistry, anatomy, genetics, not in isolation, but rather integrated. So the patient may present with weakness, urgency to urinate. The case then would unfold, and they would have to integrate the biochemical issues, the genetic issues. If this were a case of diabetes, what are the genetic familial issues, if any? What are the anatomical issues? What's the function of the islets and Langerhans? So on. So they have to put all that together. And we pick a case specifically because it engages some of those factors in the first block. Second block, you can see the topics. Third block, endocrine's pretty complex, so we kind of allowed extra time. Neuroscience is a very integrative topic on its own, and that's why there are fewer there. Microorganisms and immune response. Now, this isn't the only part of the curriculum, because the students are also getting skills. So that in block 1, they're learning to take a history, in block 2, do a physical exam or the fundamentals of a physical exam, psychosocial aspects of medicine and epidemiology. In year 2, looks very similar, again, with the topic areas around which we build the cases. You'll notice that the introduction to patient care has been flipped to the morning. Basic science PBL is in the afternoon. We do the PBL in the afternoon to take the load off the library, so that the first year students are in the libraries in the afternoon. Second year students are in the libraries in the morning. So year 1 looks like this. On Monday, Wednesday, and Friday, they have problem-based learning for the entire morning. We did not do away with lectures. This is a hybrid program, so we did not simply eliminate lectures, because lecture is a good way of learning. It just is overdone. And the lectures had to be conceptual, and they had to meet certain objectives. It isn't just come in and pontificate on whatever you want. And then in the afternoon, there were 2 days each week that were reserved for individual study. No faculty could put anything in those 2 days. We told the anatomists, you cannot tell the students, you need to be in the anatomy lab this afternoon because if you know what's good for you. Can't tell the students that. If the students came to the anatomist and said, would you meet us in the lab this afternoon and go over something with us, that's okay. So again, we put faculty in a role of being a consultant. And then year 2, you've seen that it's a reverse. And just for your information, the clinical curriculum, year 3 is what we call clerkships, internal medicine, pediatrics, specialties that they get. And then year 4 are the advanced clinical selectives, where they're actually selecting clinical blocks where they would learn cardiology, or they would learn critical care or emergency medicine, depending on which direction they're headed. So we had a problem-based learning group, facilitator, students. They're getting the case a page at a time, taking notes, discussing, developing hypotheses. You can see they've written stuff all over the board. They've written things on the flip chart. They're tracking things. get involved in a very vigorous discussion. There are 8 members of the group. There is one, what we call a tutor. It's actually the faculty facilitator. Start with a quarterback. That is one of the students who is running the discussion, and a quarterback or a scribe who's taking notes on everything. The role of quarterback and the role of the scribe rotates around, so every student gets a shot at leadership. They present new ideas, they get feedback on these ideas, they work at problem solving as a group. A lot of the students bring previous knowledge and experiences. In fact, they may get the diagnosis right off the bat. Oh, well, my Aunt Minnie had that. But the students will say, wait, okay, great, now we know the diagnosis. Let's learn the basic science behind it. And so they know that they may get the diagnosis right off the bat. That isn't the end point. It's self-directed collaborative learning and also developing interpersonal skills. Up above you see that they've called in an anatomy faculty as a consultant. And they work in groups outside of the problem-based learning group. They get together and they continue to discuss things. Now, when I got the assignment to change the curriculum, the first thing I did was okay, we're going to change. I'm not sure how we're going to change, but we're going to change. Well, when you try and bring change into a traditional setting, it's like moving a cemetery. You really never understand or realize how many friends the dead have until you try and move a cemetery. Change is hard for people. There are winners and there are losers when you have change. There are people who are going to lose something because of the change. There are also people who are going to gain things because of the change. And you have to be sensitive to that. We knew at that time that McMaster University and Harvard and Southern Illinois and Wake Forest and New Mexico were experimenting with this problem-based learning that we had heard about. And so we sent faculty to observe what they were doing. Faculty came back and said, oh, that's kind of exciting. We ought to think about it. It was a happy accident that Harvard was one of the first to move in this direction. But it really originated with McMaster in Canada. And so we thought, okay, this is kind of the way we want to go. So as the visiting teams learned about new strategies for medical education, they brought it back and they talked to other people. We wanted to engage faculty, more and more faculty, and we couldn't send them all out for visits. So we then offered problem-based learning sessions to faculty groups of 8, and they could try it out. It's kind of like try it with a drive, test drive it. So they participated in these groups, and some of them came away saying this is a waste of time, and others came away saying, oh, this has some possibilities. We developed a critical mass of faculty willing to make a change. And then we began to design the curriculum, and again using interdisciplinary design committees so that we could really talk about the integration of concepts and knowledge rather than simply polishing or buffing up the old curriculum. And so we ended up with a curriculum. We have no department courses in the first 2 years. We do not have anatomy or biochemistry or microbiology. We do not have those courses. Everything is integrated. And my mantra in the first 2 years was homeostasis. That is, the body in disease is out of balance. And that's what we need to stress to the students. Disease isn't just an isolated thing. It is when the body's out of balance in some way or another. And so we need to teach balance, and then we need to teach the pathology or the loss of balance. Now, in order to sell this, we used Everett Rogers' adoption of innovation process. If you're not aware of it, that's your learning objective. But in order to make change, people have to know or have to accept that there is a relative advantage to the new system, to the change. And so that's why we demonstrated this again and again and again, so that people would engage in the process and say, yeah, this might have some possibilities. It has to be compatible. I didn't want to go in there and say, all right, we're wiping out the old curriculum, we're going to bring in the new curriculum, and we're going to make this wholesale change. It had to be a perception that this was going to be something better, but it wasn't going to upset the entire place. The change had to be not too complex, so that's why we have a hybrid curriculum. We have problem-based learning, and we retain the best of the lectures. Trialability, that's why we let them come in and try it out as learners themselves. And observability, that is, they were able to observe. If they were really skeptics, then we invited them, once we got the curriculum going, to come in and sit down and watch the students. So those of you who know about the adoption process know that you have your innovators, who were my first group to put together the early adopters and the early majority. And it's at that point we knew we could implement the curriculum, when we had the early majority. Late majority, they joined in. And really the proof of this was when our initial class took the national board exams, the licensing exam, and they did as well as they did previously. Missouri's always been at the mean. We were still at the mean after the new learners took their boards. And so we knew we didn't do any damage. And then our board scores began to go up. And at that point, a lot of faculty said, oh, yeah, I really support problem-based learning. I was part of the group that designed this. They were part of that late majority. And then the laggards, and they're very difficult to change. You just kind of have to find a place for them, because in the laggards, you may find some of your best lecturers. People who have gotten a lot of reward out of their great lectures. And in our context, we're calling them laggards, but in their context, they're getting a lot of reward for that, and they should be recognized for that. The positives of problem-based learning: outcomes measured by national exam scores, very strong. Now, the caveat is there that the national board exams have changed. With the success of this kind of learning, the questions have become more scenario-oriented rather than one correct answer out of 5. The faculty accepted their new role. That is, the faculty effort had to go into the writing and creation of the cases and into the evaluation process, which was more like the key there was, in the evaluation process, students were given a PBL case, only this time they had to do it individually. And it was open book, open resource, but the faculty had to judge the students' reasoning ability, clinical problem-solving ability, in order to get the number of points. We also gave them a multiple choice exam. 40% of the questions came from the cases, and not 40%, 60% of the questions came directly from the cases. So only 40% came from lectures. So if you look back in our first class came in 1993, so they took their first board exam in 1997. That was when the first PBL class took their board exams. And you'll notice the yellow line. Missouri was about the mean of the national exam, and even dropped a little there and then came up a bit. But with the first exam, we were still about the national mean, which was good. I knew that nothing bad would happen to me. And then our scores began to climb. Now, people always ask about this dip and this dip and this dip. When you're only dealing with a class of 100, 1 or 2 lower scores is going to have a significant effect on your scores. This is some, I don't know, 100,000. The denominator is about 100,000 for the red line. So you don't see the dips that are affected by small changes. But now significantly above the national mean. And so it shows, at least by this one measure, that we've been pretty successful. And on step 2, the second of the exams that they have to take before graduation, you can see again Missouri at the mean, which Missouri is a show-me state where they're not going to adopt things very quickly. And so being at the mean was okay. But now we're beginning to show the increase again in the clinical exam. And so, again, a success. Now the negatives, and this is what your dean has to deal with, but the negatives are that it's very resource intensive. It's going to take funding, and it's going to take changes in your physical structure that will need to accommodate these, because, and what I'm telling you about PBL, once you've seen a PBL curriculum, you've seen a PBL curriculum. Each one is a little different, and it doesn't have to be in groups of 8. It doesn't have to be with one facilitator. It does, I think that with upper level classes, maybe you may not need a facilitator. So it can be done in a variety of ways, but there has to be a commitment from the leadership that the change is going to be a positive one and going to try it out. Scheduling and space become an issue. You may have to break out of 50-minute periods. You may have to break out of courses. Or you could try it within a course and see how it works. So there is no one way to do this. Grading on an ABCDF system is really hard with problem-based learning because it's a group learning process. And it's a problem-solving skills learning process. So are you grading individuals or are you grading the group? Well, if I'm in a group and everybody else excels, I'll probably excel too. So it's very much of a team process. What do you do with marginal performances? Because they get obscured in a group. But I've also found that within the group of 8, they will govern themselves. If somebody isn't doing their job, the group usually says to that person, you know, you need to bring up the quality of your learning objectives when you report back to us. I have found that with time, the authors of the case are omitting what they call unnecessary information, and it's the psychosocial that is the first to go among the case writers. And we have to constantly be vigilant about putting those psychosocial objectives, psychosocial learning issues back into into the case. I used the example in another group about bedwetting. Ask the medical students about bedwetting, bladder infection. You sure? Yep, bladder infection. Well, the behavioral scientists know there's a great deal more to bedwetting than bladder infection. And most of it's probably psychosocial. You may have to increase the size of your group, but because you have difficulty in finding facilitators. Remember, you have one person standing in front of a group of 100 versus trying to find facilitators for the smaller groups. And so the faculty are in a situation where they're going to have to adjust to this kind of teaching. There is also kind of lecture creep where faculty find it easier and students say, just teach me what I have to know. Don't bother me with the games and other stuff. And so there are always a group of students who just don't accommodate to this, to problem-based learning. And so they encourage more and more lecturing. Just tell me what I need to know. And students do identify the most capable and least capable students. And you kind of have to have a system that brings in the student who isn't performing up to the level that would be desirable and work with them. I was discussing with some of the faculty. I had a former emergency medical tech who was just having a terrible time with this curriculum. And it's because he was used to coming on a situation, assessing it, making a snap decision about what this is and how to accommodate it, and then getting the patient in the ambulance or in the helicopter and off. Well, he was doing the same thing with problem-based learning, so he's closing down his thinking. And so he was underperforming, but it was a part of assessing his learning difficulty. Technology and learning. I hope that University of Houston Clear Lake might look at something like a YouTube best practices or a TED Talks kind of thing as you develop. If you decide to move in this direction, as you develop some of these really effective programs, and I've heard people brainstorm about some effective programs today, and your nursing program has already moved in this direction. Record these, keep track of what works, and so you get a collection of best practices. Be aware if you're not aware of the work of Hubert Dreyfus and his brother, I can't remember his brother's name, they developed the concept of novice to expert. If you don't know about Dreyfus, that's your learning issue. The novice learner requires large amounts of information. Everything's important. So you teach history taking, they'll take a history, it'll take them half an hour to take a history. You give them patient presentation, they want to know more and more and more and more. A lot of it irrelevant, but they don't know how to sift that out yet. They depend heavily on rules, so they learn all these rules. Then as they get more comfortable and more experienced, then they become advanced beginners, and the rules can be adjusted to fit the problem. And they become translated, transformed into guidelines. So they work with guidelines rather than rules. Then the competent learner uses rules, and they're modified by experience. They see patterns. They can separate the forest from the trees, or separate the trees from the forest. And the proficient learner really becomes more instinctual and intuitive in their problem solving, need a lot less information. So as you develop the cases, if you're in a situation now that you have freshmen and sophomores, they're going to need a lot of information. Their cases are going to have to be written in a different way than your advanced students. So that's just an issue to keep in mind. Experts, interesting. A lot of the experts don't make very good teachers. They skip too many steps. They've forgotten the learning process, the movement from novice to proficient. The diffusion of innovation we've talked about, but don't, when you have faculty who won't go along with this, who don't find a place for them, see if you can find a place for them, because faculty are valuable. And a lot of faculty have talent. Now, this always reminds me the Hall of Fame coach Mike Ditka, when he was coaching the Chicago Bears, he had a quarterback who was kind of a character. And he injured his shoulder, and Ditka reported that the shoulder surgery was a success, the lobotomy failed. There he's trying to change one of his most valuable creative people into a system, and may have lost somebody. So change is difficult, and some people are not going to change, but don't lose some talent. Okay, that's kind of the formal presentation.